Thank you, Jorge. Thanks for giving me the opportunity to introduce myself to you all. Some of you I have met before when I've been here as a research fellow. I'm just going to start off by talking a little bit about myself. So my association with All3 actually goes back some time. So this is me starting as a fresh-faced 19-year-old in 1996 as a medical student. Then I did most of my specialist registrar training in the West Midlands, and I was back here, still a bit fresh-faced, as a research fellow. And then now I'm a consultant. I've clearly aged quite a lot, lost my hair, grown a beard, all those kind of things. But I assure you the aging and the beard and the whitening of the beard wasn't anything to do with working at the Royal Free. It was very much, I got married and had a child at that time as well. So, next slide, please. So I'm just going to talk about my research interests from the time I was here and those I wish to continue now that I'm back. Some of the research that's ongoing at the USO Academic Net Unit, an update on some of the closed studies that we've had ongoing over the last few years, talk a little bit about some of the studies that other people may be interested in, and then also talk a little bit about the future. And then we've got some time for some questions afterwards. So my interest was predominantly in circulating tumour cells. Now, circulating tumour cells are cells that essentially break off from the primary tumour, travel into the bloodstream, and then find a happy environment where they can grow. Now, this is a diagram which basically demonstrates what is theoretically thought to happen. A cell will break off, travel into the bloodstream, and find an environment where other growth factors will help it grow and spread develops. Now, this theory has been around since 1889, this so-called seed and soil theory, the seed being the circulating tumour cell and the soil being the environment which it embeds in later. The development of metastases is a little bit more complex than that, but these circulating tumour cells, or CTCs, have had an ongoing interest amongst many oncologists ever since. Problem with CTCs is that they're quite rare events. In the bloodstream, they only occur to usually 1 per 100,000 or 1 per million other white blood cells. To actually identify them and isolate them has always been a challenge. Lots of methods have been around for isolating and investigating these CTCs, but nothing that was really reproducible or produced reliable results. That was until 2004, when CellSearch was developed. Now, I know this is quite a complex and busy slide, but just to explain to you, CellSearch is a semi-automated machine that you can use to collect 7.5 mils of blood. It undergoes some centrifuge in a fully automated machine. Antibodies are added. Some of those antibodies contain ferrofluid, essentially iron compounds, which attach to EpCAM, which is an adhesion molecule found on lots of cancer cells. Those cancer cells are then picked up as a result of the EpCAM binding and the iron being bound to it. A magnetic force is then applied through the machine that allows these single cells to be drawn out and then brought into a single field of view where you can look at these cells and identify whether they're tumour cells or not. Because a lot of other blood cells can also express EpCAM, we need other markers to confirm whether they are indeed CTCs or not, and we do that by the addition of other fluorescent antibodies to confirm the presence of a nucleus, confirm the presence of a cytokeratin marker, which is essentially the inside of the cell, and also exclude the presence of a marker called CD45, which is found on white blood cells. So next slide please. So once we put a sample in through this machine, we get images which show us the presence of a CTC by a signal for cytokeratin, DAPI, and then a combined picture of both DAPI and cytokeratin, which show the appearances of a cell. And then we can also exclude anything that might be a white blood cell by the presence of CD45 in the channel. So this was a real breakthrough in cancer, circulating tumour cell technology. Many studies were published in breast cancer, colorectal cancer and prostate cancer, which confirmed the presence of circulating tumour cells as having important features for determining prognosis. Now, Professor Mandair and Dr. Mohit Khan did some pioneering work in neuroendocrine tumours. They found that patients with NETs also had circulating tumour cells present, and they did quite a large prospective study looking at 176 patients, and they found that the presence of one CTC in the bloodstream was associated with a more adverse outcome when looking at both progression-free survival and overall survival. Now, these survival curves, the only thing you really need to know about them is that the separation of the curve suggests that there's a significant difference in outcome. So both in terms of progression-free survival and overall survival is quite a big difference in those patients that had one CTC present and those that didn't have any CTCs present. So a lot of my research was based on this pioneering work by Professor May and Professor Kaplan. This study did leave some slightly unanswered questions because all different types of NETs were combined together. And now we know that pancreatic NETs and NETs from the midguts and the stomach and the lungs all behave quite differently. So we then developed a study really to look at the pancreatic neuroendocrine tumours in particular. Next slide. So we performed a prospective study where we recruited 90 patients with pancreatic NETs, and we looked at all the other factors that can predict outcome, such as the volume of liver disease involved, whether patients had surgery, the grade of the tumour, whether there are bony metastases or the number of sites of metastases factored in, and also the number of CTCs. Now, we found that when we did the kind of multivariate and univariate analysis, i.e. incorporating all these statistical factors together, we found that certainly patients with the grade 3 had a worse outcome, but also the presence of either 3 or more CTCs was associated with worse outcome as well. But we did find that even the presence of one CTC was quite important. So we then went on to look at those patients, next slide please, that had progression. So they had evidence of the tumour growing at the time of sampling, and we looked at what their counts, CTC counts were, and we found that there was much higher CTC counts than those patients that had progression at the time of sampling, and compared to those that didn't have any progression. Now, we often use chromogranin as a tumour marker to determine, or help us predict whether progression may be developing. Now, although we also compared the two, when we looked at chromogranin levels in patients that had progression and didn't have progression, although the high levels are somewhat higher, there's quite a lot of overlap if you look at the number of patients who have elevated levels of chromogranin but don't have progression compared to those that do. We did some more statistical analysis on this and found that the sensitivity of a circulating tumour cell, one or more being in the bloodstream, of predicting progression at the time of sampling was actually 80%, which is compared to chromogranin, which is around about 60%. So very impressive figures. So on the basis of this, we certainly feel quite confident that circulating tumour cells can now be incorporated into our clinical management. Now, so circulating tumour cells. So as part of my research, so the advantage of these circulating tumour cells using that previous technology is that they help us to provide an accurate prognosis, a more accurate prognosis, I should say, alongside all the other factors that we look at. But the disadvantage of using that technology is that it didn't pick up CTCs in everybody. We only picked up CTCs in about 50% of patients with midgut NETs and about 35% of patients with pancreatic NETs. Now, what we really want to do, we want to gather as much information as we can from these circulating tumour cells, not just about counting them, but trying to look at the molecular. Got a question?
Is the circulating tumour cells, the count, what's the total volume of blood that's originally taken?
So it's 7.5 mils. 7.5 mils of blood. So that's quite a useful point because that's partially what was the theory behind this technology being developed. So, as I said, we want to identify circulating tumour cells in all patients with neuroendocrine tumours so we can look at the molecular characteristics that might help us inform future management or develop a better understanding of the way tumours develop and metastases develop. But to do that, we really need to get more tumour cells from more patients. So what we then did was we investigated a fairly novel type of technology to help us identify and isolate more of these circulating tumour cells. And some of you very kindly took part in this study as well. So the study, the device is called the CellCollector. Essentially, it's a long steel wire that sits in the blood vessel just via a regular cannula that you would have had previously when you have your scans. And the top 20 millimetres of it is plated in gold, and that sits in the blood vessel, so it's therefore in contact with the blood. Now, whilst it's in contact with the blood, it's in contact with approximately 2 to 3 litres of blood, because we leave the wire in place for about 30 minutes. So if you can imagine, it's in contact with so much more blood than just taking a snapshot of 7.5 mils. Theoretically, we should get a lot more circulating tumour cells. Yeah. So the way that the wire itself works is, so as I said, it has a gold-plated end of 20 millimetres, which sits in the vein. Attached to that is a layer of hydrogel, and attached to that is some more antibodies to target EpCAM. And so EpCAM is this molecule that sits on circulating tumour cells, and antibodies that attach to it will help the target cells, in this case circulating tumour cells, stick to the wire. Now we performed this study in about 35 patients who kindly took part, and we compared it to the other technology, CellSearch, and we found that in 34 out of 35 patients we were able to identify at least one or more CTC with this technology, which is certainly much more impressive than the CellSearch. And in the direct comparison, we found that in 30 out of 34 patients, there was always more CTCs associated, found with the CellCollector than the CellSearch itself. Now, these are certainly quite impressive figures, and now there's ongoing research to try and take these cells off the wire, to split them open and take the DNA out so that we can perform further analysis on it. So that's where my research is up to date. Just going to talk a little bit more about the research at the UCL academic unit. So you may not all know, but the UCL's academic net unit encompasses quite a wide variety of departments, and this is all the research is all coordinated by Professor Kaplan. We've got many world-class research programs with the Cancer Institute, also with cardiology, with nuclear medicine, with radiology and surgery. And also, Royal Free is the lead recruiter for a number of clinical trials in the UK and across Europe as well. I'm just going to talk a little bit about some of the research projects that are ongoing. Next slide, please. So Professor Mandair, some of his current research projects are looking at the immune landscape of neuroendocrine tumours. So a lot in the media about immune therapy for all cancers, and this is certainly the way that cancer treatment is going in the future. But as yet, we don't really understand what the dynamics of the immune system in neuroendocrine tumours really is, because as we know, neuroendocrine tumours are very different to other types of cancers. So what Professor Mandair is working on is to try and get a better understanding of the interaction of some of the immune pathways, some of the immune cells, in order to help develop future treatments. He's also currently working on looking at the role of fibroblast growth factor 4 receptors in the circulating tumour cells and determine whether or not they have an impact on the development of bone metastases. And he continues the work that I was working on using quite cutting-edge technology to do further molecular profiling of circulating tumour cells in neuroendocrine tumours. So Dr. Chrissy Thowell, I think you may have met before, who's presented her very exciting work about integrated genomic analysis of small intestinal, bronchial and neuroendocrine tumours, which she's published in the New England Journal of Medicine in the last couple of years. This study is ongoing just to try and generate as much information as we can to help us develop predictive models about neuroendocrine tumours. Alongside this, she's also analysing circulating free DNA, which is in some ways comparable to circulating tumour cells to identify prognosis and get more information about tumours, but has the advantages in that all patients will have some circulating free DNA around. Next slide, please. So just to talk a little bit about some of the clinical trials that we have ongoing at the moment. So biomarker studies, and by that I mean something in the bloodstream that gives us an idea of how the tumour may be behaving. So on the back of Professor Mandair's research with Mohit Khan, kind of CLARINET study is open. It's been recruiting for 2 years now. Basically that study is to assess the value of circulating tumour cells in patients that get commenced on lanreotide autogels, whether they fall, whether that is associated with a symptomatic response or associated with a radiological response, i.e. the tumour getting smaller. PNETS, now this is a study run by Professor Mandair and by Chrissy Thirlwell, really trying to get as much tissue and as much blood as we can from any patient that might be having any surgery or even having a biopsy. In order to do a lot of these genetic studies and to look at the immune variation, we need as much tissue as we can. So this study is ongoing and we're recruiting to it as we move forward. So, as I said, we collaborate very closely with the nuclear medicine department, and there are a number of studies that are going on at the moment. One of the main studies that is currently open is the Dototech study, which is looking at the safety of gallium-68 Dototech as one of the isotopes that they put in when you're having a gallium scan. Just trying to determine the correct dosage, the optimum dosage to get the best results possible. Another study that's going to be open in the next couple of months, I think, it's basically looking at using a different isotope. So alongside gallium-68, which is used as one of the isotopes to highlight tumours, copper-64, which is shown to have quite encouraging results in other tumour types, is another isotope that's going to be combined with gallium-68 to determine whether or not that increases or improves the sensitivity of picking up disease around the body. FODMAP is another study that's currently ongoing at the moment. We're in collaboration with Hammersmith Hospital. Essentially, it's just to look at a different type of isotope and compound to just see if this also helps aid in the diagnosis or the staging of neuroendocrine tumours, and we're currently recruiting for that at the moment. In terms of therapeutic trials that are due to open, now this is due to open certainly in February. Essentially, it's looking at giving lanreotide autogel to patients who have had their first-line therapy, so they may have had chemotherapy, and then have stable disease afterwards, and it's often a question as to whether or not we should have them on anything after that. Hopefully this study will help us answer that question. Next study. So this CLARINET FORTE is again due to open in 2016, so this is to determine whether the benefits, putting patients on higher doses of lanreotide autogel, i.e. having it every 2 weeks rather than every 4 weeks, can be associated with any improvement in symptoms or halting any further disease or tumour growth. SECTOR is a study that's is in setup as we speak. I think it has been taken on board in the US. Essentially, it's trying to determine what's the patients that are due to have chemotherapy. What is the best sequence of treatment? Is it chemotherapy, and then if they then progress after that, everolimus, or is it everolimus first, then followed by chemotherapy? So it's an unanswered question. Hopefully this study will help point us in the right direction for that. The next study, again, this is going to be organised by the nuclear medicine doctors, and a very exciting study. It's looking at lutetium that we know of, but attached to a different molecule. So normally we've used dotatate or dotatok, which is an agonist, i.e. it binds to somatostatin receptors. But there's certainly encouraging preclinical studies that suggest an antagonist rather than an agonist can have much higher, much tighter binding with these somatostatin receptors. So it may be that using that compound, you get much closer, much tighter sticking to the areas of active disease around the body to allow the lutetium, the radiation, to be released. The opening of that, I mean, it's a collaborative study with Basel. We're hoping that's going to open in the next 2-3 months. Currently, we have the FODMAP diet study, and it really is for patients who continue to have lots of GI symptoms, predominantly diarrhea, abdominal discomfort and bloating, and not related to disease progression and not related to anything else like bacterial overgrowth. It's a randomised prospective study. It's been run by our lead dietitian, Tara, and essentially it is open at the moment if patients want to get involved. What we look at is really putting patients on either standard of care treatment, which is this booklet. Has everyone got a copy of this? I've got a few spare if anybody wants one. Which is, dietary advice that we recommend for all patients, versus the low FODMAP diet. Now, low FODMAP diet has been quite successful in managing patients with irritable bowel syndrome, with diarrhea, predominant irritable bowel syndrome, but mostly by cutting down the amount of lactose, fructose, and fructans that you ingest. It's thought to help by cutting down the diarrhea and also decrease the stretching of some of the bowel. And if anyone's had any bowel surgery or any bowel operations or any treatment that interferes with the bowel absorption, you would presume that some of these compounds that you have in regular part of your diet may well make a difference. So cutting them out could be beneficial, but that study is still ongoing. So just to talk about some of the closed trials that we've had ongoing for the last couple of years. These aren't yet been published, but I have got the results from a lot of the European meetings. So if I just talk about AAA NETA study first of all. So AAA NETA study was a phase 3 study, so it's essentially comparing lutetium, which is our preferred treatment of choice in terms of peptide radiolabeled receptor targeted therapy, against high-dose octreotide, 60 milligrams, in mid-gut neuroendocrine tumours with progression found on scans, i.e. growing tumours not found on scans. Now, the results have been presented at the European Cancer Congress and also at the North American Neuroendocrine Tumour Society, and they've been very, very promising. We only have the interim results so far, but so far we have an objective response, i.e. patients who had indeed had a partial response, a shrinkage of tumour of 19% in the patients who had the lutetium, and we had disease stabilisation in a further 66%, which is very encouraging results. The safety profile was as expected in previous studies with lutetium, which was showed that side effects were just as tolerable as they were with the higher dose of octreotide. Next slide. So unfortunately it's not come out very clear, but again these are more survival curves, and I think all you really need to know is that where there's a difference between the two curves, that shows where there's a big gap between the two curves, that shows quite a significant difference. So this is progression-free survival, the time before patients have any further growth of the tumour. And these patients in green are those that were having the PRRT, and shows that there's a much slower rate of progression than those patients that went on to the octreotide. And again, looking at survival, overall survival, there's quite a significant difference between the two. Moving on to Telestar and Telepath. Now, this was a study that was to determine the efficacy of terlitrosat etiprate, or Lexicon, which is commonly known as, which is a tryptophan hydroxylase inhibitor. Essentially, it tries to cut down the production of serotonin. It's been found to decrease, as a result of that, the amount of flushing episodes and the diarrhea. Now, the results of these two big studies that aren't yet been published, but certainly a previous phase 2 study, when it was really looking at the response and the correct dosage, found that the bowel motions decreased on average by 2.6, so 2.5 times a day. There's a noticeable decrease in flushing episode, and also in the urinary 5-HA, one of the markers, metabolites we look to measure the disease activity. The results of this study will be published, I'm sure, in the next couple of months, but they aren't yet available. The other quite large study that's been ongoing across Europe is a randomised control study comparing everolimus, one of the mTOR inhibitors, with placebo. Now, patients who had, so in the past we'd had positive results from patients who had pancreatic neuroendocrine tumours, but this was to look at all other types of neuroendocrine tumours arising from the bowel or indeed from the lung. Again, it's quite a big study, 302 patients recruited, 205 patients have received everolimus. Very encouraging results again. So there's a 52% reduction in the risk of progression of patients releasing everolimus compared to those on placebo. So again, another survival curve, but if you just see the patients in blue are having everolimus, looking at progression-free survival, there's a clear difference between the two, occurring at a much slower rate. So again, this was very encouraging for us all. So a lot of people have been asking about oncolytic viruses, and I can only really comment on oncolytic viruses as to what's in the public domain, because it's work, although we do closely collaborate with Uppsala University, at the moment it's very much in the early stages. Now, the oncolytic virus, the theory behind it is it's a genetically engineered virus that enters tumour cells, and once in tumour cells it grows. Once they grow, it can cause those tumour cells to burst, and also attract a bit of an immune response, which might also help kill off the tumour. Now, they've been talking about oncolytic viruses for some time, and as yet, the only studies in it have been performed on animal models. So we don't know yet how well that's going to translate to humans. There is, looking at the press release last week, they now do have the funding in place to conduct a phase 1 study, which is to look at, see whether the oncolytic virus itself in its form is safe. And then studies, and that, to determine that will take about at least 2 years, and then after that there will be patient recruitment. So certainly if there is any, if the phase 1 studies are successful and they move to phase 2 and 3, i.e. when patients are recruited, it certainly will be involved. Okay, so just in terms of the future of research in neuroendocrine tumours, so we continue to try and develop predictive models of disease. As you know, that some tumours, even if they have the same grade or the same volume liver involvement, they still behave differently. We want to try and understand better how tumours behave, and certainly the genetic analysis and the epigenetic analysis and circulating tumour cells identification will help build a bigger picture as to how each tumour is likely to behave in the future. As I mentioned, Professor Mandair continues his work on looking at the immune environment around circulating tumour cells, There will be immune-targeted therapy coming available in the next few years, and we'll be in a good place to determine whether they're likely to work in neuroendocrine tumours or not. When I talk about molecular targeted agents, there are things like sunitinib and everolimus, and they've been around a little while now, but there are newer drugs similar to that who work at a specific part of the tumour development pathway that will be becoming available. And again, we'll be in a good place to take part in any of those studies. And also we'll continue to collaborate with TransNet, which is the UK-wide research and translational research foundation for neuroendocrine tumours, and of course with all the sites and centres around ENETS. Just like to thank obviously Martin and Tim and Christos and Chrissy and all our specialist nurses that have been involved. And certainly like to thank the NET Patient Foundation, CRUK, ECMC for all their help with funding all the studies that we've taken past. And also like to thank you. So certainly we wouldn't be in such a good place where we are with patient recruitment of studies, fundraising, without all of your help. So I'd like to thank all of you, all your friends and all your relatives for increasing awareness of neuroendocrine tumours and for taking part in our studies. Thank you.
Thank you. Is there any questions for Dr. Mandair after the presentation?
Question.
Yeah.
If it was over his head, it was way over my
Sure,
head.
okay.
But post-diagnosis of tumours, NETs, and you do the research, have you done any research pre-diagnosis so that people would be aware of symptoms that they may get 5 years, 6 years before perhaps the NET is detected? I don't know what time span pre-diagnosis. I've read that it's usually once the tumour's metastasised that you realise you've got a problem, but the problem then is a little bit too late. So it seems to me with NETs that half the battle is to perhaps find it earlier when it's capable of treatment by surgery, possibly.
Yeah, that's a good question. The problem is obviously that a lot of these, these tumours are always regarded as being silent tumours. So when patients don't have any symptoms, they won't seek medical attention, they won't get scans done. Often most of our patients present when they have the kind of classic carcinoid symptoms of diarrhea, flushing, wheezing, breathlessness, or if it's a lot of pain that they're having, or if it's some of the functional symptoms associated with pancreatic tumours that are producing too much insulin or VIP. So it's very difficult to pick up patients when they don't have any symptoms.
Changes.
So you wouldn't not necessarily detect any hormonal changes, certainly in carcinoid syndrome, until things are spread to the liver. So it'd be very difficult. There's no real blood tests or markers that can help us identify these things.
You haven't done any research in terms of patient question-answer sessions. Did you have any pains? Because for years before I had it diagnosed, I used to get what I thought was simply tension.
Sure.
And it sort of gripped me like an increasing tightening corset. But I thought it was stress, and if I relaxed, it went. Now, I don't know if that's symptomatic with other patients. I also felt perhaps getting too old, my testosterone levels fell as well, but I hadn't associated it with any bigger picture.
Sure.
But now that I'm progressing in terms of treatment and that, I start to ask myself more questions. Were there things that identified issues that could have been, if people were aware of the possible symptoms, they could say, well, I've got irritable bowel syndrome, Mr. GP, but I also have. So somebody could start to pre-think the situation.
Sure. I mean, certainly is, if patients aren't having symptoms, then we can't put them through really any investigations. But yes, when we meet patients for the first time and talk to them about their history, then they often give us similar story as you say, pain coming and going, unexplained weight loss, unexplained diarrhea. They can put these symptoms actually having been there for some time. Part of the problem can be trying to persuade your GP or your gastroenterologist that you see to take these symptoms seriously. there's no, as I said, no blood test that a GP can do in his surgery that will pick up the disease early, unfortunately. But part of the reason why we're seeing more and more tumours being diagnosed is certainly because patients are being sent for investigations more early. GPs are becoming made more aware, other gastroenterologists are becoming made more aware of, well, you know, if you've got some unexplained symptoms, could this be something else? Could this be a neuroendocrine tumour? And we can only really address that by increasing the awareness of neuroendocrine tumours. And yes, certainly, you know, as someone with a bit of unexplained abdominal pain, you know, you should be, you need to be speaking to your GP about getting the appropriate investigations.
The danger is that they're temperamental symptoms, in as much as if you have a headache, it goes away.
Mm-hmm.
If you have a stomachache or diarrhea, it goes away. So you don't sort of question it. And you don't think because I have, a loss of a certain hormone that it's a cancer.
Yeah.
So yeah, okay, thank you.
The initial symptoms are often not related to the hormone being released itself. They're it's more, but they're usually related to the tumour itself growing and just affecting some of the blood vessels or the lining of the bowel. That's usually where the symptoms start from. So the hormone levels again might not necessarily be picked up till a bit later on.
I also would add for that research that you were saying, that imagine like at the moment the incidence of neuroendocrine tumours is around 3-4 per 100,000 in the UK. So if what they're suggesting, that is a really good idea, but if we put it on the large scale, all the people that might be having those symptoms that tend to be quite inspecific of any condition, imagine how many people you would need in order to identify in a very early stage early signs of neuroendocrine tumours. It would be in itself unfeasible. You would need like millions and millions of people. In the research, which is the funding that it's given from the pharma industry or from academic sources, it's limited. And in the end, we end up having like maybe 200 patients, 300 patients. The large scale of doing like a millions and millions study with that kind of, to be able to analyze prospectively those symptoms is extremely, extremely difficult, unfortunately.
Just ask a question, please. On the last point you made about GPs, I think my voice is loud enough anyway. Then you talk about GPs. I went to a GP and with diarrhoea. I was going to the toilet after meals, almost immediately in restaurants, this kind of thing. The question he never asked me, which may be a question that all GPs should ask, is, have you got any flushing? Which I did have. He never asked me, and then I carried on until it was found out from a different scan. So there are simple questions that they can differentiate between the 200 people or millions of people. If the GPs are aware of certain questions, you can have certain problems. And he just said to me, well, I'm the same as you. I have to go 3 times a day or 5 times a day. I thought, well, it's very normal. But he didn't, and I've got to start to get flushing. He just said to me, have you got flushing? And I said, yes, but I've known something straight away. So there are some simple things that if GPs are educated, if you pardon the expression in those terms, then they can, as soon as somebody goes to bowel syndrome, do you have any flushing? Then yes, they can be referred to.
I have to be careful what I say about GPs. My wife's a GP. She might watch this. Yes, but I think the problem is that GPs, obviously, this is still a very rare condition. Not the rule-free, but it is still a very rare condition. So they may not know the right questions to ask. You're right. We can try and help that by increasing awareness, which a lot of the work that you guys are doing and the Net Patient Foundation are doing does help increase that. Net Cancer Awareness Day that we have each year. All of those things do increase the consciousness. But certainly, if your symptoms are persisting and the GP hasn't got an answer for it, there are guidelines that suggest the GP should be referring you on to someone who might know more, like a gastroenterologist, who may not have seen a neuroendocrine tumour, but certainly would have been taught about them at some point. Question over here?
Yeah.
Oh, okay.
I just wanted to ask about timing and what is the origin of timing. So this is a very rare condition.
Yeah.
And it starts with the primary, or is there some precursor to the primary? Is there research of why would a primary start off in the first place?
So a very, very good question and a very difficult one to answer. I'll do my best. So,
Sorry, what was the question?
So the question is about the primary. Are there any precursors to the primary tumour developing? Where does it originate from? Is that right?
Yes.
Yeah. So essentially, tumours are a growth of cells. So and then we have neuroendocrine cells all across the body that have important functions. You know, they can release some chemicals and hormones that you need just to help absorption or help lubricate some of the surfaces of the bowel, the surfaces of the lungs. So all these cells have a very important function. A tumour develops, and you always have cell turnover because you don't have the same cells all the time. Cells do their job, and then they die, then they go away. In any cancer development, it's when cells, that switching on of cell growth and switching off of cell growth and making sure cells die when they've done their job, that just stops working. So you just get uncontrolled growth of all these cells, which then coalesce to form a tumour. So that's the nature of these tumour cells. These cells that do exist in your body, they do an important job, but then you have uncontrolled growth. Now, what the trigger of that growth is, we don't know. We don't know yet. And it's the same in many cancers. We don't know what the trigger it can be. It could be environmental factors or genetic factors in some other types of cancers. We haven't found that association in neuroendocrine tumours as yet. We know that some genetic conditions like MEN1, VHL1, these are associated with a higher risk of neuroendocrine tumours develop. So genetics must certainly be involved. But as yet, we don't know exactly which gene aberration or gene abnormality might spark off the neuroendocrine tumour from starting. There is ongoing research into this all the time here in Europe, and hopefully those questions will be answered, but they won't be answered very quickly.
You just partly answered my second question, which was, are there any genetic markers? But the first question was actually, are neuroendocrine tumours age-related? I don't seem to hear of many children having neuroendocrine tumours.
So it's very rare to have for them to occur in children. If they do occur in children, it's usually as a result of a genetic, an inherited genetic mutations like MEN1 or VHL or neurofibromatosis. So in isolation, it's very, very rare. They tend to occur in the appendix, sometimes in some of the other glands in and around the neck. So they're very rare. The pancreatic and the midgut neuroendocrine tumours are very rare in the young. The average age of incidence is about 45, and I think a bit older in men. But what we don't know is exactly when that tumour may have started. So we can only infer from with the results of when patients come to us to see in clinic and say it's about 45, 50. But there isn't really any association with age, just because we have patients that present in their 80s, we have some patients that present in their late teens. And age itself doesn't seem to be that important a factor when we do the statistics. So, what age you present, does that have a significant impact on how you're going to be overall, or how likely you are to progress? All the statistics that I've done and my predecessors have done as research fellows haven't found that age has that much of an impact. Just a number.
Thank you. I understand that the majority of your research is fairly scientifically based. Have you also tried to analyse the effect of certain diets on neuroendocrine tumours and also exercise, and whether detoxification, for example, and taking foods which feed your immune system might make a difference, and also has there been any research into these areas?
So not as such in neuroendocrine tumours, not any research that that's involves a kind of appropriate trial setup of a control arm and an uncontrolled arm. So we don't really know of any benefits of particular foods that might make a difference. Now, in lots of other cancers, liver cancer, prostate cancer, there's always something in the media about this might be useful to prevent cancer, or this might be useful to prevent cancer from getting any worse. But a lot of that research is based on epidemiological studies, and that basically means that it's what people have said in surveys. So certainly some of the research you can take on board, but some of it you have to be very careful about. Certainly in neuroendocrine tumours, we haven't aren't aware of any obvious foods or any obvious diets that make a difference. But that may be just because the research just hasn't been done. It's often quite difficult research to organise. We know from our patients, and certainly from our work our dietitians done, that some food will help with symptoms and is better for some of the symptoms like the abdominal discomfort, the bloating, the diarrhoea, but we don't have any evidence that it has an impact on the disease process as a whole.
Sorry, could I just pick up on that? Because I think it's well known that certain, if you're juicing, for example, that certain vegetables do have sort of anti-cancer agents within them. So my feeling would be that if you can take those vegetables, then you're actually doing more good than harm.
So I certainly agree. I think, again, the evidence, we look at the kind of the evidence and the studies that are published for these things, and I have looked at a lot of certainly some of the factors in prostate and liver and breast and other types of pancreatic cancer that can be affected. But the take-home message is always, a well-balanced diet. So if you're eating well, plenty of fresh fruit, plenty of vegetables, meat in moderation, alcohol in moderation, that's always the take-home message. Selectively having much higher intake of, curcumin or turmeric or any of these kind of compounds, there's not strong enough evidence to say that's what you should go on. So although, yes, there's lots of research ongoing about it, the take-home message should always be just eat sensibly, eat plenty of fresh fruit, eat plenty of vegetables. If you suffer from a lot of GI symptoms, then you might want to just modify some of that just to help with your symptoms as a whole. But there's no strong evidence to suggest that, if you eat 10 tomatoes a day, whatever, that it's going to make a real difference to neuroendocrine tumours. Some evidence for it in other tumour types, but again, it hasn't really been looked at in neuroendocrine tumours as much. And as a result, we can't really comment, as we know neuroendocrine tumours are quite different to the prostates and the lungs and the liver cancers.
Okay, this question about the rate of growth of neuroendocrine tumours. I was led to believe that tumours still grow.
Yeah.
So when they found tumours inside my liver, I was told that they could have been there for years.
Yeah.
Slowly growing, and I had no symptoms that I was aware of. Now, these tumours have been removed by surgery, but if there would be recurrence of the tumour, if there's still CTCs circulating, I don't know, but some primaries were also removed from the gut. But let's say that a tumour occurs in the liver, what's left of it. How slowly will it grow? I mean, whatever latest know-how is on this comes through. So, I mean, even if it does recover, maybe it's so slow growing that it's not going to kill you for quite a while.
So that's a really good question. It's a question that we do get asked quite a lot. The problem is that we don't know, we really don't know how quickly, once a tumour comes back, how quickly it's going to grow. And a lot of that is because we don't know enough about the tumour itself when it first presents, because as we established earlier, patients often present when the tumour's already spread. So it's really difficult to say how long it may take. Part of the work that we're doing in collaboration with University College London is to try and look at these tumours so we can actually try and identify genetic markers that might help us predict which one's going to come back in 6 months, in a year, 12 months, 3 years. And that is ongoing. Similarly with circulating tumour cells, we know that if circulating tumour cells are present, the tumour is more likely to grow quicker than if they aren't present. But trying to incorporate that into a clinical model is what we're trying to move forwards to. Until we get a model there we can put numbers and figures in and come out with an answer that says, yeah, this is how quickly this is likely to grow. We're not any nearer answering that question. But I think as time moves forward, we will be.
Okay, this is a question I probably didn't ask my consultants. And that is, if nothing had been done and my tumours were just left alone, how would they kill you? And, you know from your experience with many patients,
Yeah.
what their history is. So I'd like to have some idea of the fatality kind of index of NETs.
Right. So
how they actually kill you.
So it can be due to a number of reasons. It depends on where your tumour is and where it's come from. But if it's a tumour that's producing lots of hormone, the so-called carcinoid syndrome, and it's usually as a result of the side effects of the carcinoid syndrome. So it can be fibrosis affecting the heart, making the heart valves not work very well. It could be as a result of your breathing deteriorating just because of the ongoing wheezing. Outside of the carcinoid syndrome, it can be just because the tumour grows too much and starts pressing on other organs, starts pressing on the kidney, starts pressing on some of the vital blood vessels that stop drainage of some of the veins. That's usually the latter stages. I mean, in the majority of neuroendocrine tumour patients, certainly it's not your neuroendocrine tumour that's going to be the final thing. You live for long enough, and we aim to keep you living for long enough that it's something else. So those are the things. I hope that's not too morbid for you, but I'm just trying to say that it's not the neuroendocrine tumour that we would hope that would be the final thing. The symptoms of severe carcinoid is one way, and it's normally a mass effect from the tumour the other way, or it's spread. Oh, it's got a question down here afterwards.
So one thing I would like to pick up on that, which was just said, my wife had neuroendocrine tumours, and we were always having tests done to see how they were progressing and everything, and progression was very slow. And which we were told at the beginning. First of all, when she has surgery, we were told that the chances are it would then never reoccur, never be a problem again. Unfortunately, that we came to the Royal Frey and did an excellent job on that, which was fantastic. One thing we did notice, though, when picking up on what the gentleman said, was Alison regression with the neuroendocrine tumours, although they were progressing and they were growing slowly, that wasn't the problem. We had it later on in the stages. It was, we were always told that they were not particularly progressive, it was great. One thing when we did have a problem eventually was the scar tissue, which had been caused by the surgery. That's what I believe, that was the problem we actually had. Certainly Alison definitely had to have surgery, there was never a question of that, and she really did have to because she was bowel blocked and all things, there was not an option. But it was actually the scar tissue which caused the major problems with other organs. Yeah.
So, could I ask where the tumour was? It a midgut?
It was a small bowel.
Yeah.
Small bowel, and then eventually it was on the liver as well.
Yeah.
But the liver one was never a problem. It was never a problem.
So the scar tissue, we have a specific name for that tissue. It's called desmoplasia, which essentially refers to fibrosis, and it is a result of the tumour. It's not just of the surgery, but it's mostly of the tumour releasing some of the chemicals. And some of those chemicals, what they do is they cause thickening, fibrosis and matting of the lining of the bowel around it. And then that can start attacking some of the other organs as well. So yes, that is quite a common finding in about 25 to 30% of patients with midgut neuroendocrine tumours. There isn't there's a lot of research being done about it mostly in the US actually, some in Europe as well, and there's not been any real breakthroughs in what to do about that. We certainly know that the earlier that you identify, the earlier you put on the analogue injections can slow down the rate of that developing. But once it develops, there's no drugs or no therapies that are yet available that might slow it down. So it is an important thing that there is ongoing research into. In all honesty, there haven't been any developments in it in the last 10 years. I think as we understand more about the mechanism of fibrosis, and at the Royal Free we do talk with some of our other colleagues in some of the other departments where fibrosis, this kind of thickening of tissue, is a real problem. We do talk to them to try and get some ideas about where we can push forward our research, but yes, certainly in the last 10 years we haven't really moved any further forward in that.
We just talk about PRRT.
Yes.
My wife's undergoing treatment with the LU117 dositate.
Yeah.
You talked about something else appearing, an antagonist
Mm-hmm.
called JR11.
That's right, yes.
Is that now available?
So it will be a clinical trial.
And they're all free?
And they're all free, so I think it's going to open in 2 or 3 months' time.
Right.
And I'm not sure what the inclusion and exclusion criteria of it is, because it's been run mostly by our nuclear medic doctors and Professor Kaplan. But it will be an option for patients who are progressing and who we can't get the funding available for lutetium as things stand.
Right. If someone's had lutetium already, will they be able to have the JR11?
I imagine not immediately, because it will interact with because it's still because it will be too much radiation, number one, and you may not get quite so much of the active drug being taken to the place of interest because of the recent treatment. So I imagine not immediately. It probably would be a washout period of maybe a year or even 2 years before that would become available.
Thank you very much.
Okay.
Would it be very difficult to devise a questionnaire for all patients, like there used to be questionnaires, a dietary questionnaire to ask specific questions about diet, and for somebody to correlate with type of disease, disease progression, etc. I don't think it would be very difficult, but why has it never been done?
So we do, obviously we have our questionnaires at the start of clinic where everybody fills in about the symptoms that they're having. I imagine you're asking this to see if we can pick up on symptoms in addition to other symptoms that might indicate things are changing or things are progression. Is that?
I would not like to speculate
Right.
what you might pick up,
Sure.
but I would like to know that any correlation could be picked up if somebody looked at it.
Yeah, I think it's an interesting point. I think it would be useful to certainly look at some of the symptoms and some of the foods that you eat, but how we could apply that to, and it certainly is something that was worth thinking about. I don't think it has been done before in terms of correlating your symptoms from that sheet alone. Obviously, when we see you in clinic, we ask about your bowel frequency and your flushing and pain, wheezing and breathlessness, and those are for us the most important questions that we want to get answered, because it may be that your scans aren't showing much change, your hormone levels aren't showing much change, but you're getting a lot more symptoms. So we do always insist on, those questions should always be asked each time we meet you in clinic. In terms of getting a little bit more objective evidence by getting those questions filled in, that certainly is useful. Certainly something I could mention to our dietitian to see if we can take that forward.
Definitely.
Just going back to the PRRT again, you mentioned that there's this sorry, I didn't make a note of before it was called. I wasn't able to have PRRT despite only having it in lymph nodes where it had been left behind, because I was told that it can cause other problems, and so say that someone basically wait till you're worse.
Yeah.
And then we'll try it, rather than try and use it now to get rid of it, which was sort of what I was hoping for. This new one you're talking about, is that something that they could potentially try instead? Or is that going to damage organs as well?
So it will have similar side effects to the lutetium itself, because the only difference between this drug is that lutetium is the active drug. That's the localized radiation that gets released. It's the carrier molecule. It's the carrier molecule. So before it was DOTA-take or DOTA-toc, which is essentially an agonist, which is essentially the thing that binds to the receptors or where the disease is present. And the tighter it's bound, or the more receptors it's bound to, the more the drug gets released. The theory is that these antagonists, so they actually block the receptors rather than activating the receptors, they bind a lot tighter for longer, so they would release more of the drug. But the drug itself, it's the lutetium that causes the side effects of kidney problems and bone marrow problems. So it is, the use of lutetium, we have to be careful when we use it. You know, we have to always weigh, whenever we make any decision in treatment, it's always about weighing up the risks versus the benefits. And if it's, you know, if there's not been any change, the disease isn't growing, then you know, our treatment is to carry on watching and waiting before any change happens. We haven't got enough evidence to say, let's put you on this, you know, very potent, but you know, heavily, often quite risky drug, without waiting to see what happens.
Well, what about if there was something, because I have got, in February last year, they found something then 4 by 6 centimetres in my lung. We still don't know what it is. I've had needle biopsies and whatever. Lots and lots of tests. I've been in hospital and I had lung surgery in October, thanks to this scarring that we were talking about. They did start and they did get so far into the lung, but couldn't actually get a tissue sample. So I'm now a year on where they don't know whether it's inflammation or whether it is further spread of carcinoma in the lung.
Sure.
How long should I go on for just not knowing what it is? You know, it could be more. They have increased my dosage of lanreotide to 120 because the lymph nodes were getting a bit bigger as well. But if surgery is not an option because apparently it's too dangerous, would at that point, is it worth going back to them again and saying, look, now can we go PRRT, or would they not do it because they don't know what it is still?
I think what they'd need to do is certainly, I mean, it's difficult to comment on each individual case, but they would need to do some more imaging to confirm it is a neuroendocrine tumour, and that would usually be with a gallium PET scan. So have you had one of those recently?
Not recent. I'm having another, but they've had to wait since, because obviously if I had the operation in October,
then you get a lot of scarring around it, yes, which are positive, yeah.
So but not a gallium scan, it's a CT scan in the liver and things like that.
So I think if that shows any obvious change, then the sensible thing would be for it to have a gallium scan, just to see if there's any, to confirm whether it's got hormone uptake. Because if it doesn't have hormone uptake on the gallium scan, the lutetium isn't going to do anything to it.
Right. Well, it does a little bit, but they're saying that might be, apparently you can also get uptake if it's inflammation.
But so that's after you've had your, so that's why they're letting the scarring and the inflammation, most of it settle down.
Last year,
yeah.
They said, well, there is some, but we're still not sure. There's a positive uptake on the lymph nodes. There was a little bit, not in the whole of the mass, but on some of it. And they were saying that you can get positive uptake if it's inflammation. So we're still at the...
So I think the key is, you know, is it growing? Is it changing? And does it take up enough of the somatostatin? Does it have enough somatostatin receptors found on the gallium for lutetium to actually work? Because if there isn't enough uptake, then not enough of the drug is actually going to go there in the first place. Right. So that's another reason why we just have to, you know, see what the next lot of scans show.
Can I just ask you how you choose patients for the trial?
So there is inclusion and exclusion criteria for all of these drug trials. I don't have a full list of them for me, but if you think that you might be, you know, suitable for any one of these trials, then, you know, usually we'll try and pre-select you and talk to you about it in clinic. But if you're keen to know, you can certainly ask us, or you can ask Melissa, our specialist, our research trials coordinator. Yeah, sorry, a question here. Yeah.
You've used the word binding with these active molecules on active sites in the tumour. Actually binds? Is it a chemical reaction or is it a physical reaction?
So it's a bit of both. So it's a bit of both. It's essentially a receptor that's got a particular shaped hole in it that the molecule comes along and attaches to, and then there is a chemical response after that.
Like a lock and key.
Essentially, yes. Jorge, just a question.
Thanks. I'm going to have my last lot of treatment in a few weeks' time set for the targeting therapy, which I believe the funding has been withdrawn for. I'm okay because I'm halfway through the system.
Yeah.
Did the funding ever get reinstated, or is it still withdrawn?
So,
Just a matter of interest. It doesn't affect me.
Sure. So as things stand, the funding has been withdrawn from the Cancer Drugs Fund as of the end of last year. So, but any patients that had already been started on treatment before then, the treatment will continue. I can't comment too much because this is very much what Professor Kaplan's dealing with, and he's dealing with the Department of Health and NHS England and the government and just about everyone to get this back on formulary. Now, we've got very strong evidence, as strong evidence as you can have from a clinical trial, from the AAA work that I mentioned earlier. So it's hard for any of us to see why there has been this no. It will go to NICE next year, and they will almost certainly approve it. But it's a question of what we do in between now and then. So, Professor Kaplan, as I said, he's very much involved, so I can't comment too much about what exactly is going on, but, he will be, appealing on all the patients' behalf to try and get this treatment back for us.
Can I ask, is it being withdrawn because it doesn't cure me? It only postpones. Is that what NICE are thinking?
So this wasn't NICE. This was the Cancer Drugs Fund that said no. I have to honestly tell you, we don't know why they said no. Professor Kaplan may know more, but I think just because of the Cancer Drugs Fund, it's been squeezed in terms of money and funding. Before, this drug was run without a license, but we knew it was really effective. Part of the reason for the AAA study was to show it got worldwide acceptance as a drug that was very effective. But we already knew that because we had so many patients, hundreds of patients that benefited from so much. So Professor Kaplan, as I said, has presented all this data to the CDF. It's in a state of ongoing appeal, and I can assure you that Professor Kaplan, myself, Dr. Tupanakis, all our research nurses and our clinical nurses will carry on pushing to get this treatment back for those that need it.
Anyone more last question?
On a similar vein, your PRRT treatments, how successful are they going to be for NICE to accept them, considering they've already taken itching off their list?
Yeah, so again, the evidence that we have in this huge worldwide study is pretty convincing. So it's just the process now of going through NICE. So they'll wait for that study. It's not yet been published. They'll wait for the final results to come through, and then they'll meet, I'm told by Professor Kaplan, next year. On the basis of this, I can't see how they would say no, but I'm not in NICE to be able to say this is why this shouldn't happen, this is why it should happen. But just looking at other drugs in other conditions, so as a gastroenterologist, I look after Crohn's and ulcerative colitis as well. We've had newer drugs that have become available over the last couple of years that have then been NICE approved, also very expensive. But because the evidence has been so compelling and so convincing, NICE have been obliged to approve them, and we hope that will be we strongly think that will be the same case for PRRT. The problem is it isn't likely to happen before next year.
Thank you. Well, thank you so much, Dr. Mandair, for your talk and being so eloquent in answering all the questions. They actually have been really tough, some of them. Thank you so much.
Thank you. Thank you.